Welcome once again, or perhaps welcome for the very first time. I don't pretend to know who you are. Welcome into the Radiopedia Reading Room for a podcast unconcerned with books or poetry, tea leaves or palmistry. It's a radiology podcast. My name is Andrew Dixon, and joining me, a radiologist who loves nothing more than to be on the front line, down in the trenches, hot reading cases as soon as they come off the scanner. It's my co-host, Frank Gaylard.
I am not a trench kind of guy. I would be awful in any sort of conflict. I'd probably be that guy. You know, in movies, there's that trope of the extra who panics and just rushes out of the foxhole and gets mowed down by machine gun fire. That'd be my designated role in any kind of conflict.
FYI, for listeners, military radiology is the topic for today's main segment, hence this little military chat. So, Gaylord, if you had to be in the military and could pick any role, what would it be?
Can I be a radiologist?
No, that's cheating. Something else. You've got to say something nerdy like logistics or cyber warfare.
I mean, yes, but out of all the things that you could do in the army, there are many that are at the very top of my do not want to be. And that's pretty much anything that involves confined spaces like tanks or submarines.
Oh, you don't like confined spaces?
I'm not claustrophobic, but the idea of being in a tank just sounds ghastly. The submarine, no way. There's a submarine up in Sydney, I think. Yeah, on the harbour in Sydney, there's an old submarine that's been decommissioned that's open to the public, and you can wander around inside it. It's awful enough on the surface, and the thought of being inside that thing 30 meters underwater when others are trying to kill you would just be, and there's so many people that you can't get away from. No.
So you're not going to volunteer to man a mission to Mars or something?
No, definitely not. Not unless I went on my own with the dog.
I don't think that's the best way to start a colony on Mars. One man and a dog. It's like we come back 100 years later. There's nothing. He didn't reproduce at all.
Maybe reproduction by mitosis is the way to go. You just sit there and gradually split into two.
It's probably enough radiation. You probably could. But anyway, getting back onto it. So what would you be?
I don't know. If I had to be something, I guess some kind of pilot of some sort. I'm not saying I'd be any good at it. It's probably where I would be the least terrible. And certainly I should not be put in any position where I have to make tactical or strategic decisions. My boys defeat me wholeheartly at StarCraft every time we play. It's just embarrassing, and have been doing so since they were about 6 and 8. No, I'm conflict adverse. You?
I'm not sure what role I would like in the military, but instead of answering that, I might tell you a quick story from my childhood. So one of my grandfathers, he served in World War II, and he was arguably not even 18 years old when he signed up. Anyway, he was deployed to Borneo to resist the Japanese. And I still remember the first time when I was a kid that I was told that Pa had been to war. And it shows how kind of my youthful innocence at this time, because I only knew him as a butcher. He was like an expert selector of beef. He supplied meat to lots of places around Melbourne. And he loved to cook dinner and barbecues, right? So my child brain, when I heard that Pa had been to Borneo during the war, I just assumed he wasn't a soldier. I assumed he was there on the beach cooking barbecues for the soldiers.
Yeah, really relaxed. It was such a good time.
Lovely cut of meat for the men on the beach there. Turns out he was not cooking a barbie for the troops each night. He was actually in the war. So anyway, as I mentioned, this is a military radiology episode and an interview, actually. And it's actually one of those rare Frank Gaylard managed to record a main segment type of episodes. Frank, do you want to explain what you have in store for our listeners?
Well, it all goes back to that other classic episode I recorded with veterinarian radiologist.
One episode. Sorry, continue.
With veterinarian radiologist Kathy Beck. I think it was episode 30. And one of our listeners, Yulian Dragushin, I hope I said that correctly, wrote in and said, "Hi guys, I thought I'd write to you to express how much I liked the last episode that you did with the veterinarian. I'm a military general radiologist in San Antonio, Texas, and have 2 Chihuahua mutts who I love." I wrote back and asked him what it was like to be a military radiologist, as I'd never really thought about what do radiologists do in the military. And I was particularly interested in what it would be like to do radiology deployed in an active conflict. And also, how do you train for the kind of injuries that you're expected to then look at? Anyway, one thing led to another, and Julian was kind enough to get me in touch with two of his senior colleagues who have had deployment experience. It took quite a bit of work to get approval from the US Army Public Affairs and everything sorted. And I can't thank Julian enough for not only giving me the idea, but also for pretty much doing all the organization that it took to get this to happen. And I feel kind of bad that he doesn't actually get to be heard on the episode, because it definitely wouldn't have happened without him. Anyway, what I have for you, Dixon,
and
is
our dear listeners.
What I have for you, Dixon, and our dear listeners, is a chat with two United States Army radiologists. Colonel Michael Wirt is a radiologist and Chief of Department of Radiology at the Brooke Army Medical Center at Fort Sam in Houston in San Antonio, Texas, USA. And Colonel Aaron Betts is a certified adult and pediatric neuroradiologist and pediatric radiologist, section chief of MR Imaging and MR Medical Director, also at Brooke Army Medical Center. But before we kick off, I just need to formally state that the views and opinions expressed by Dr. Wirt and Dr. Betts are their own and do not reflect the official policy of the U.S. Army, the Department of Defense, the Army Medical Corps, or Brooke Army Medical Center.
That's cool. You need to go with a bit of a deeper voice though with that. The views and opinions expressed by podcast guests on today's episode do not reflect those of the U.S. Army policy. Something like that.
Something like that. Or the guys that read the complications or side effects of drugs on US.
I was watching the Super Bowl yesterday, and they have this guy with the deepest voice you've ever heard saying, "Stay tuned for the halftime show." Like, just ridiculous. Totally American. So let's listen into this episode anyway, and I'll hit play, and then you and I will be back for another chat in the outro.
Michael and Aaron, welcome, and thank you for making the time to talk to me today.
Well, thank you for having us.
Yes, thank you for the invitation.
The reason I wanted to get you both on the podcast is it feels like there's many conflicts at the moment going on, perhaps more than during most of my life, at least. And a lot of the discussion that we see online or in the press is really at a strategic and tactical level. And my mind keeps being drawn to operational questions, the logistics of how things work. And particularly as a radiologist, how does radiology fit into these various scenarios, and how does it differ from civilian practice? So they're the kind of areas that I would really like to get into with the two of you. But before we get into some of these questions, I'd like to start at the beginning and just find out, how do you become a radiologist in the military?
Well, for American military radiologists, the pathway looks really similar to civilian radiologists. So you get a 4-year or bachelor's level undergraduate degree, and then from there you go on to medical school. Most of the radiologists that come into the Army, which is my experience, but I think that's probably true for across the services, will end up taking a scholarship through the military through what's called the Health Professions Scholarship Program, or we have a military medical school in Bethesda, Maryland called Uniformed Services University. And through the Health Professions Scholarship Program, they would attend any accredited medical school in the United States. The military would pick up the bill for tuition and then give a stipend for living expenses and books and supplies along the way. Uniformed Services University, you're actually at active duty while you're a student. So for the scholarship program, you're a reservist. You don't wear a uniform to class. Nobody would know you're a military student unless you told them. But at Uniformed Services University, you're considered active duty. That's where I went to medical school, and so I wore a uniform every day to class, and I got paid as a second lieutenant to be there, and it was tuition free in terms of monetary. Now, the tuition you pay is years of service. So whenever the military gives you something and picks up the bill for it, you pay the military back in terms of years of service.
And what's the retention rate for after your time is up? How many people stay in the military versus then go out into the civilian practice?
I think that's a variable answer. It varies depending on what year you were asking. So if it was a soft market for radiology and there weren't a lot of jobs out there, I think a lot of people would stick around because it's a guaranteed job and it's you're not making a transition into a rough job market.
So one tension that I expect exists when trying to plan your workforce as radiologists, particularly for a large standing army like the US Army, is that most of the time you need radiologists to cover the same spectrum of disease largely that civilian radiologists do, but you also need to simultaneously have the capability of pivoting to conflict type of radiology, which would be completely different in terms of gunshot wounds and barrow trauma. And how do you balance that from a training point of view and from a subspecialty point of view?
Yeah, one of the things that we have gained from experience, unfortunately, from the long war in Afghanistan was an iterative nature of improving what we do in our training programs here locally and then translating that to what we do in wartime. One of the things we've established, we have something called the Joint Trauma System, and that's an Army, Navy, Air Force derived system that monitors and tracks all the trauma data from all the combat theaters. And we take that and we use it as performance improvement data. And we look at whether it's the golden hour and the time from injury to the first surgical hospital, or what procedure did we use in the field? How did it work? What type of tourniquet was applied? Was it applied correctly? Well, and then link all that to the patient survival. What type of body armor were they wearing? What type of wounding pattern did you see? Do we need to change the body armor to help better protect the soldier? Do we need to transfuse whole blood? Do we need to transfuse component therapy? All that stuff is measured and looked at. So translating that back to radiology, what we established at Brooke Army Medical Center here in San Antonio was a methodology for scanning the trauma patients for CT, or even the trauma survey and the trauma pathway. So you come in the ED door, you go to the trauma bay, you call the trauma team in, the trauma team does their surveys, the radiology team comes in, shoots the x-ray. Okay, next step is go to CAT scan, or they do a fast ultrasound scan, and then it goes to the CT, then it goes to the OR. And so that process, when we do that here in San Antonio, that is the exact same process that we're using at our combat support hospitals in the theaters.
Okay, so that's something I really want to dig into a little bit, because in my very civilian brain, I know what my department looks like, and what you've described is exactly what happens at my hospital. That's also a trauma hospital. I've also seen how long it takes to commission a CT scanner in my hospital, which is months. And so when you suddenly have to have an expeditionary force and set up shop, how do you get a CT scanner up and running? Presumably within, a couple of days at most.
We have these called the ISO shelters. It's essentially a lead-lined box that the CT is already pre-positioned in. We do have some contractors that will come and help facilitate the essentially the commissioning of the scanner, but we also train teams of medical technicians where they're certified to work on these types of systems. And we'll bring a CT into theater in a box and we'll commission it and get it ready to run. We just kind of fold out the doors and expand the shelter, close everything back up, make sure it's set in a location that's appropriate for radiation protection, and then go from there. And then you have to have your trained technologists, and you hope your technologist is well trained in operating a CT scanner, which would seem to be obvious, but is not always the case, because all radiology technologists are radiology technologists, but not everybody has the same level of experience, and not all registered CT technologists. So when you're bringing combat support hospital with all their structure, and then someone can't deploy for some reason, and it maybe that was your CT tech, and they say, well, we'll just substitute another radiology tech, they may or may not have the same level of experience.
That's an interesting point, because even in my experience, we tend to focus on the big hardware, expensive items. And often that's not the most difficult thing to get right. It's the human component of that system. Presumably, the problem is also modality dependent.
To some degree, there are different roles of care. Role one would be, near point of injury. So you have your medic on the ground who takes care of the individual who's injured immediately. They bring them the closest medical facility where you might have a physician assistant or a single doctor. They will take care of that patient and try to stabilize them. They may have a handheld ultrasound unit. That patient would then be transported either by air or ground to, if possible, you'd move directly to something called Role 3, which bypasses your Role 2 or Level 2 hospital. The Role 2 has a little bit more capability, might have a surgical team that's associated with it, usually has 4 or 5 doctors, has an x-ray unit, has a portable ultrasound unit, like a tabletop.
Mm-hmm.
And that is about the extent of imaging capability we would have there. We tend not to hold patients much longer than about 72 hours at Role 2 because you never know when you're going to get more, or you might have a mass casualty event, and you always need to continue to move patients to maintain your flexibility. And then you move those patients to this Role 3, which is that combat support hospital. Typically in Afghanistan and Iraq, we would be able to have a CT scanner at that location because they're not always associated with those hospitals, but most always in our most recent experience, they have been. So CT, ultrasound, x-ray, sometimes fluoroscopy. You could do some minor interventional procedures. You could certainly do CT guided procedures. And then the CT is the number one tool for trauma assessment.
It is hard to imagine dealing with anything without CT. I mean, in our practice, as we joke, a family history of trauma is enough to get you a full scan.
The interesting dilemma that we're in right now is we were very used to this low intensity conflict. And for radiology, then we have a fairly set piece plan. If we come into theater, we go to the Role 3, we act like a radiologist at a Role 3, and that Role 3, we fall in on the scanner. It's already there. It's been there for the last 5 years. There's upgrades and things you want to do. You're there for about a year. You do everything you can, and then you go to then you come back home. As we look at the world right now, we look at potential for larger conflicts. If we look at a conflict in Europe, if we look at a conflict in the Asia Pacific, would we still have the ability as radiologists to come in and provide the value of being on site, having a CT scanner there, when that support hospital may have to pack up and move and not be in that fixed location? That requires a lot of infrastructure. It's easier to fly one in, truck it over from the airstrip and put it in a hospital. But if you have to continue to pack and move it, it becomes a lot more complex. And then you're worried about getting that set up, getting the instrument validated, making sure you're not damaging the instrument on movement.
Presumably, you also need to model expected rates of casualty. And in the recent times, particularly with the conflict in the Ukraine, the idea of very large number of casualties, how does one prepare for that? Because the number of CT scanners that you need to deal with thousands of troops per week or day is a very different one to the kind of conflicts that we've seen previously.
It's a very difficult planning problem. It's really dependent, I think, on the number of combat support hospitals that you can have in theater. There's really not the infrastructure to manage more than a CT scanner or so per location. I was fortunate to have 2 CT scanners at a Role 3 combat support hospital in Afghanistan, down in the Helmand province. It was Bastion Hospital, and they had 2 CT scanners that were the control rooms for the scanner, and the radiologist reading area was co-located, and then the scanners were on each end of the control room. And we were able to then work mass casualty events very efficiently.
Mm-hmm.
But that was very fortunate in an unusual situation. Mostly those hospitals would have just one scanner. And then it becomes the surgical triage. As the patients come in, the trauma surgeons are there triaging, and they're really racking and stacking the patients for going to the OR immediately. We're not even scanning them, to, okay, next one, this one needs a CT scan. This is my number one priority. And then we backwards plan all the rest of them down to the people who can wait. And they are then either put into the ICU to stabilize and then brought over. So it's really the trauma director and the radiologist are really two of the key players for working and orchestrating that trauma flow. And at Bastion, the radiologist would do the fast scan, then have to race over to back to the scanner room if it's a single casualty. If it became multiple casualties, the ER docs could also do the fast scans and help.
And do your trauma protocols in CT differ from in that mass casualty setting? Do you tweak the way that you scan at all to speed things up, or is it essentially as fast as it can be already?
It's pretty fast. I mean, our trauma protocol was a non-con head from the vertex down through the mandible, and then immediately a contrast study from Circle of Willis down to mid-thigh. If we didn't suspect a lower extremity trauma and a vascular injury, if we suspected that, we'd scan down to the feet, and it would be a single pass, and then that would be enough with the trauma surgeon standing over us watching the images come out to then make a very quick decision on, okay, these are the big things.
So Aaron, that's an area that I'm interested also, is the training that you require to become comfortable with the kind of injury patterns that you would encounter during conflict. There's an element of it which is, are you actually seeing these kind of injuries? So you guys, because, USA, we know how you feel about guns, you get to practice that element, I suppose. But even then, I expect that there's differences between military gunshot wounds versus civilian firearms. But then there's the whole element of landmines and barrow trauma, which is something presumably you don't experience. So how do you deal with that element? And then how do you deal with the replicating the psychological stress of having so many injuries coming up at once?
Well, first I'll address the question about how to train for those types of injuries. So certainly being at a level 1 trauma center, yeah, we're going to see gunshot wounds, and we've had nights where we see multiple the same night. And actually I've seen patients that have had old gunshot wounds and that have had come in with new gunshot wounds. So I've got comparisons showing which ones were the old ones and which ones are the new ones. So I have a theory. I don't have research to prove it, but my theory is that being shot once is a risk factor for being shot again.
I think that sounds like a safe hypothesis.
As far as the injury pattern, it's not always like a direct, imagine, a straight line going right through like an impaling type injury. It can it can take unusual courses, and the bullets can break up, and then so you can have different fragments of the bullets going different directions and causing different types of injuries. So it's something that the more you see them, the more you start recognizing different patterns, and you're looking for major organ injuries and hemorrhagic injuries along the way. As far as the blast type injuries, yes, that is something that we don't typically see with regularity in a civilian setting. And so when you encounter that type of injury pattern in a military environment, you're essentially doing your same kind of trauma assessment, but then you're giving it a little extra eye for things like what kind of lung injuries can we get from like a blast overpressure type of injury. And then you're really looking with a sensitive eye for any areas of hollow organ perforation.
And do you have like teaching files of cases that your residents would go through of these kind of injuries?
We have what's called a military unique curriculum. And so the residency curriculum will have the standard, neuroradiology, mammography, body imaging, pediatric, and then one of the modules we cover is military unique curriculum. But during active combat operations in Iraq and Afghanistan in late 2000s and the 2010s, the severe combat injuries that were being evacuated to our hospital, we would continue to see these patients. So when you were on call one night, a bus show up at the door, of trauma evacuation patients that had been, cared for at the role 1, evacuated to a role 2, stabilized at a role 3, and then air evac'd back to the United States. And now we're seeing them and re-imaging them. So though we're not seeing the fresh combat trauma injury, we're seeing it 72 hours to weeks and months later.
Presumably, also, it would be ideal if your subspecialist radiologists did not have to be next to the scanner in theatre, that you would farm out all these reads to be read by people back in the States or in other areas nearby. Does that happen at all, or is it really largely the radiologist next to that scanner that is responsible for reading those images?
It's a little bit of a combination of both. Currently, it used to be the radiologist standing next to the scanner was the sole provider for that patient, and there wasn't a significant backup. But now, just I think we've leveraged the teleradiology capability and really started to expand it over the last couple of years, where that capability exists now. It's been done in a rudimentary form for a long time. We have a different type of PACS imaging system that we use in the combat theater. And now what we're working on is developing communications between that type of a PACS system, being able to send the images, then shift them over to our current PACS system here in the US.
So the three of us are all neuroradiologists, and we've spoken at length about CT. What, if any, role does MR have outside of existing sort of large hospital bases?
Aaron and I talked about this a little prior to the podcast, and I was in the combat theater, not serving as a primary duty as a radiologist, but as something called the brigade surgeon. So I was with an infantry brigade out at a forward operating base near Kandahar, and I heard word that Kandahar was going to get an MRI scanner, and they knew I was a radiologist, so I got consulted about the idea, and that actually came to fruition. We ended up having 3 MRIs in the Afghan theater, and we thought, oh, this is going to be great because traumatic brain injury was, the hallmark, silent injury of the war. We were struggling for ways to really evaluate and decide, okay, does this person need to be evacuated from theater? Can this person be rested and recuperated and then potentially remain in the combat theater? How do we disposition these soldiers? So the MRI we thought was going to be a great tool. It was very expensive to get into theater. It was expensive to maintain with the liquid helium and trying to keep it up and running. And in different parts of Afghanistan, we have widely varying temperature ranges during the days and nights. And then the obvious question is, what about retained foreign bodies? And so most of our injuries were blast injuries and not gunshot wounds. There's a number of gunshot wounds, but if you look at our data, it was mounted in vehicles hitting IEDs, or it was dismounted patrolling, stepping on IEDs. So all this blast injury had multiple fragments of stuff that would be inside the patient, whether it was bones, rocks and dirt, explosive devices, wood, everything. So we'd have lots of foreign bodies, and then putting them in the scanner was a significant risk. So it ended up, what do we image with the MRI? Was musculoskeletal injuries, typically. So we were doing knees, ankles, and shoulders, and the type of injuries that active soldiers will get while they're out on patrol or when they're playing basketball when they have some time off. And
you touched on interventional radiology before, but how much of a role has that grown to play in contrast to operative, open techniques? Because in the civilian space, we're doing more and more embolization for, pelvic fractures that are bleeding or solid organ injuries. Has that seen a role in the combat theater, or is it still just too hard to get that organized?
Well, in my experience, we did have some interventional radiologists who deployed and some radiologists who were experienced enough in interventions that they could help facilitate those at the big centers. So in Afghanistan, it would have been at the major combat support hospitals. In Kandahar and in Bagram, we had some interventions where we could perform those routinely. But I think it was always limited by the fluoroscopy, and we'd have a C-arm that we could use and do your best you can with what you had.
That brings, I think, to another point that we explored before this meeting, was about the, not conflict, but the differences between the two roles that you have. On the one hand, you're a medical practitioner, a radiologist of variable seniority, but you also have in parallel a military career. And presumably your seniority in those two arms don't always match up and stay in sync. So there must be situations where you're far more senior in one role than in the other. Does that occur? Does that cause any problems, or are there, tried and true easy ways of delineating responsibility according to medical versus military rank?
That duality is probably one of the things that defines a military physician, is the fact that you have a rank and you're also doctor, and then what people around you may address you as may be contextually different. So if I'm talking to a patient, I would introduce myself as doctor. If I'm talking to my hospital commander, he or she's going to address me by my rank. But yes, as far as the differences in seniority and experience, that does come up. So for example, we've had residents come through our program that, maybe had a very successful career outside of medicine prior to going to medical school, but their rank has still continued to accrue. Or we've even had residents who have switched from different medical specialties, so internal medicine or family medicine, decide they want to be a radiologist. And so they may be a lieutenant colonel or even a colonel by the time they start as a brand new resident. And so the staff teaching them may be a relatively fresh out of residency captain or junior major, and they're educating a full colonel. Generally, it doesn't cause much of a conflict in that sense. I've seen a couple of situations where personalities and egos may have trouble learning from somebody of a lower rank. But generally speaking, when you're in training, you understand, and especially as daunting as radiology is when you first start to learn it, the learning curve humbles you very quickly.
What about when someone gets injured? Does their rank still count when they're a patient?
We really try not to do that. And I think that that's one of the strengths of our military system. We really work hard to defer to expertise and not defer to rank.
In terms of patient care, especially addressing the mass casualty situation, I can't recall a time where I even knew a patient's rank. Really what we're operating from is, what are the resources we have? How many patients do we have to take care of? And then we start going through triage, the delayed, immediate, minimal, and expectant. From a radiology standpoint, the decision then becomes, okay, who is your most severe? Who's your most critical? Who's your immediate? They'll be first on the scanner, and then we form the line, and we will just start scanning them from there. The first step is almost like the radiology equivalent of a primary survey. So what are the big things that you need to know? The free air, pneumothorax, any retained bodies, anything that looks like active bleeding. That all ends up becoming jotted notes on a paper, verbal communication, and then you move on to the next patient. And then eventually, once all the patients are imaged and they're being either moved to the OR, being stabilized in an ICU, then we actually start going through the more formal process that we're all familiar with as radiologists, and documenting all the findings and the injuries. Mm-hmm. In our hospital here in San Antonio, Texas, as a level 1 trauma center, we train all of our residents that when they're on call, every trauma that comes through our scanner, they are at the scanner with the trauma team.
So that hot read at the scanner, I think, is crucial everywhere, not just in the military. But I find a lot of my trainees are really hesitant to put themselves in that space with the trauma surgeons next to the scanner. And it is quite a confronting situation. But the reality is that hot read is going to happen. The question is a radiologist going to do it, or is the surgeon going to do it on their own? And the moment you frame it that way, I think it becomes obvious that you need to be in that room.
Yeah. And I think it's important for our residents that they do that, because I will say I'm a fairly introverted guy walking into a crowded console room with a bunch of surgeons. It was an intimidating exercise to go through. But when you go through that exercise enough and you get the comfort level, then you arrive in a combat scenario with multiple injured patients, and you're around a bunch of surgeons and a bunch of ICU docs and the ER docs. You've done that enough times. So even though there may be some variability in the severity and the types of injuries you're seeing, that exercise is something you've done multiple times.
If we circle back to our discussion on teleradiology, the radiologist in the room at the console is a critical component of the trauma pathway. We've practiced that so many times with the surgeons now. They rely on us, they want us there. And so if we were to move to teleradiology as a primary way to read those studies from the combat theater, that would change how the surgeons view the radiologist. They're there, they're taking the risk. They are in the combat zone. There's just part of we're all sharing the experience of being there, and we're all on that team. I saw the same thing at Bastion. We would come in, the room is absolutely jammed with surgeons and support staff and ER docs and everybody else. When the radiologists come in, the room would go quiet.
Yep.
And it would be probably the lead trauma surgeon and the radiologist sitting there going through the case together, and then boom, triaged, moving out, and then the next case would go in. The room would get less populated as, if we had multiple traumas, the surgeons would have to be taking them to the OR, and then we'd be running information in. We were always a key player, and I think that's, being there is half the fight on that.
Well, there is that saying that radiologists are the doctor's doctor. And I think that's really true because it's giving that cross-specialty and broader view, which is one of the challenges of going down a increasingly subspecialist radiology pathway, is that you lose that holistic understanding.
I think that's one area where the military has maintained more of a balance between the generalist and the specialist. While we do have subspecialty trained radiologists, there is an expectation that every subspecialist is also a generalist, for that very reason that you may be a women's imaging specialist, but when it's time to go to war, you're not going to war to read screeners. You're going to war to be a trauma radiologist, which is a lot of general radiology. There's neuroradiology, there's body radiology. And so I think that's one area where we've sort of resisted as a military out of necessity, that push towards extreme specialization.
Well, thank you both for your time today. I could keep talking to both of you for much longer, but I think this is as good a place as any to stop. Thank you for your time.
Thank you.
Well, thank you for having us today. Really enjoyed it.
Thank you to Colonel Betts and Wirt for speaking to Frank for that interview, and to Colonel Sanders, of course. I can't mention two colonels without mentioning the man who came up with the secret herbs and spices.
How does the pronunciation of colonel come from colonel anyway? That's one of those words. I even had to look it up just to make sure I wasn't having a stroke.
I found that discussion really interesting. At one point, I think you summarized, Frank, that the human component, the human resource of providing imaging is often the hardest part. Getting a physical machine itself is not the limitation. And that reminded me of a situation when, and it's happened a few times at my hospital over the years, that someone donates a scanner to the hospital, like a mobile MRI scanner. They donate the hardware, but it doesn't come with the funding for the MRI tech who's going to run it, or the more radiologist time to report those extra scans that it produces. The thing we actually need is the human to do the job, not necessarily the hardware.
It's much less exciting for politicians to stand in front of a business case or a contract than it is to stand in front of a shiny piece of equipment where they can get their photo. And what a lot of places need is, yes, they need the MR, but actually they need the teaching, and they need a stable power supply, a generator that works. Those are much less exciting, but actually much more important advances. And Radiopedia tries to fulfill some of that role by providing the kind of teaching and education and mentorship that is so difficult to get in countries that don't have a culture of doing that. So I think the human factor is really difficult.
Yeah, I think you've hit the nail on the head that it is all about, when they donate a machine, it's all about the show. It's all about those pictures, but that's not actually what's going to result in greater and better healthcare being delivered. Anyway, that's barely related to the topic of military radiology, but it's just something that I thought of as I listened along. I must say I was a little surprised by the lack of teleradiology and interventional radiology use in the military theatres. I thought that the military would have been like way ahead of civilian radiology in terms of these types of technology, because, military is often a massive funder of these kind of new
Yeah.
technologies.
Yeah, I was a bit surprised by that as well. But I think the point about being in the room was a really important one, not just from a cultural point of view, as in you, the radiologist, are deployed along with the surgeons and the radiographers and the nurses, and it feels right to share that experience. But also because I guess, particularly in a peer-to-peer conflict, you can't rely on good connectivity or internet. When you look at the conflict in the Ukraine at the moment, electronic warfare is a huge part of that. And you would worry about making yourself reliant on treatment of having a high-speed connection to somewhere else. But yeah, I was a bit surprised as well. And the interventional radiology thing, again, goes back to the human factor being the hard thing, because you would think embolizing things would be really useful in conflict, but the difficulties of setting up that extra equipment and getting interventional radiologists everywhere, whereas training someone for interpreting trauma to a degree is much easier than training someone to embolize things. And it's not just the radiologists, it's all the support staff as well.
But it is interesting because I know that interventional radiology is so important. I work at a major trauma hospital, and it's a really important part of the management of so many patients.
Yeah.
Even injured patients getting an IVC filter to prevent PE would seem like that would come up relatively frequently. Maybe they have to get transferred out for that kind of thing. But it seems like such a standard part of our care that, I was a bit surprised that it wasn't used more. And the final thing I've written down here, again, not very military related, but just a random thing that I thought about as I was listening along. The three of you spoke about that duality between doctor and military rank.
Mm-hmm.
And it made me think, and you probably experienced this even more strongly than me, perhaps, Frank, there is a bit of a duality between Radiopedia Andrew and radiologist, colleague, lowly worker bee at the hospital Andrew.
I think that's an interesting part of the discussion that we had as well. And recently I was chatting to a couple of our outgoing trainees who, on their very last day, admitted to being listeners of the podcast. So if you're listening, hi, Lucy. Hi, Edward. Anyway, and I was asking them if there was much of a difference between work Frank and podcast Frank. And they graciously said no, although I am much more filtered here than I am at work. And, you and Murph probably not infrequently cut things out because you think I'm going to get myself into trouble. I don't know. I don't listen to the podcast. Who knows? Maybe I'm not even in the podcast.
For example. But, I don't mean necessarily that I act as different people. It is just the fact that within the radiology department, largely by design, I'm kind of swimming down the bottom, getting my work done, not involved in the leadership type things.
Right.
And so I have colleagues who are very much more senior than me within the department hierarchy. But when it comes to education, global recognition as a radiologist, I am, because of my Radiopedia Association, far more senior than almost all of them in that respect. So just that duality exists.
Yeah, no, that's true. The other thing that I was just thinking about the other day is that our notoriety as educators sometimes gets confused as being really good radiologists. I'm not saying we're bad radiologists, but, I'm well known as a neuroradiologist, way above how good a neuroradiologist I am. There are probably thousands of neuroradiologists out there, many of you, dear listeners, who are, as radiologists, far better than I am. And yet, because you don't have the platform and Radiopedia, etc., you don't get heard of. And those things sometimes get confused.
Yeah. I have an example recently, or a few years ago, actually. We had a neuroradiologist visiting us from Colombia, and she was extremely thankful for Radiopedia, telling me how fantastic it was. Thanks for all the lectures. Thanks for this. Thanks for that. You're amazing, kind of stuff. And then, she's sitting in with me while I'm doing some neuroradiology reporting, and her level of knowledge was way, way beyond my level of knowledge. She was teaching me things left, right, and center. There was one bit where I'm dictating out a cervical spine report, and she's like, I think you mean C23. And I'm like, oh, yep. And she's telling me all this stuff. She was fantastic. So Lena, if you're out there, thank you. You have much greater radiology knowledge than I do. But yeah, it is kind of artificially elevated because of the platform that we have through Radiopedia.
Yeah, and the interesting thing about the rank issue that Michael and Aaron were talking about is, I guess, that it exists very much concurrently for them, because they're at the very same time, they're both in the military setting and medical hierarchy, and they need to switch between those two potentially, instantaneously.
Yeah.
They take an order from one person 1 second and then are giving that person medical orders the next. And obviously they're just used to it and it works and everyone understands which role they're in at any given moment. But I thought that was an interesting part of the discussion.
All right. Well, I reckon we probably should wrap this episode up, Gaylard. How can people get in contact with us?
Well, we're at Radiopedia on X and Instagram, as well as at Frank Gaylard and at Dr. Andrew Rickson. And you can, of course, email us at podcast@radiopedia.org with any ideas and feedback.
Yes. So Lucy and Edward, if you want to host a main segment of the
Yes.
podcast, then reach out to Frank.
Actually, both of you would be really good. You can do a readful. You could do it together.
Lucy and Edward podcast. Could be good.
I'm going to tune in.
And if you want to help support Radiopedia, you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping to give free conference and course access to people in 125 low and middle-income countries.
And Radiopedia 2024 is starting to warm up, isn't it, Dixon? It's getting closer. I can feel it every day. There's more things happening.
Did I show you what I got delivered to the house the other day?
I saw the photo. That was very impressive.
The wife got me a special neon light with the Radiopedia logo for the conference on it. So that may sneak its way into the background of some of my
that'd be great.
lectures for the conference.
I actually got into trouble with my wife because of that, Dixon.
Why is that? Because she hasn't bought you anything related to Radiopedia?
Yeah, I showed her the picture and I said, well, you don't get me that. And she gave me the greasiest look. And she said, well, you can marry Dixon's wife if you want.
Well, she is the official wife of the podcast. So.
No, that looks amazing. I think it'll look great in the background.
And what else can people do to help us out, Frank?
You can also help us out by leaving a 5-star review in the podcast app of your choosing.
Absolutely. All right. Well, we'll catch you all again sometime soon in the reading room.
Aye, Captain. Stay rad. Stay rad.
Aye, Captain.
It's not even Army, is it?
Hey, sailor. All right, I'll see you in a couple of weeks, Gaylard.
Bye-bye, Dixon.
Bye.